This week on the BackTable podcast.
Patients really do express a huge amount of frustration with access for care, especially acute access when they have these symptoms. And so, hey, it's not unreasonable. It's in fact quite understandable. But the problem, I think, is that to have that conversation takes time. A lot of people as clinicians don't have a lot of time, and we need to find a way.
Yeah.
We need to find that time, I guess. We need to find that ability to take that extra little bit of time to counsel them, like you're talking about counseling them about the potential long-term consequences of excessive antibiotic use.
Hello and welcome once again to BackTable Urology Podcast. I'm your host again today, Dr. Suzette Sutherland, and I'm super excited to have Dr. Lennie Ackerman with us today from the University of California, UCLA, to discuss with us some issues pertaining to our microbiomes, and specifically for urology, of course, our urobiome, or the microbiome of the urine and the urinary tract. So thanks for being with us here today, Dr. Ackerman.
It's wonderful to be here. Thanks so much for having me.
First, before we get started, let me just tell you a little bit more about Dr. Ackerman. She's really an expert in this area. As I mentioned, she's at UCLA. She's an associate professor in urology there, but she also serves as director of research in the Division of Urogynecology and Reconstructive Surgery. She's always had an extreme interest in the microbiome of the bladder, and again, as I said, considered an expert in this field nationally and internationally. Her current research at UCLA looks a little bit more specifically at the host microbe interactions, right? And how that translates to lower urinary tract symptoms, or what we call LUTs in the urology world. So why don't we start with that? A little bit more about an understanding about the microbiome of the bladder. I will just say a quick little aside. When I was a urology resident, I had people ask me all the time, why urology and not general surgery? And I would say a little tongue-in-cheek at the time, because urine's sterile and stool's not. But we know from a lot of work that you've done as well that urine is actually, in fact, not sterile, and that's what the microbiome is. So tell us a little bit about what you found in the bladder.
So the body really hosts a very wide range of microbes in almost every place that we have. So almost every body surface and every hollow viscous organ, and almost anywhere where there's an interface with the outside world, there's going to be a microbiome. And these are microbes of all types, not just bacteria, but that live in these different locations and that actually play a big part in regulating all of our sort of normal physiology. And so on the skin, we have bacteria, we have fungus. We actually have quite a bit of fungus that just lives on our skin. And they actually help regulate sort of that surface interface with the outside world and our immune systems and how permeable that layer is. And we think that the same thing is going on within the bladder, that surface, that inner lining of the bladder hosts a diverse microbiome. And some of the stuff that my lab has done and some other people have done to demonstrate that it's not just bacteria. There is actually also fungus in the bladder. There's probably lots of other things as well. We know from other people's research that there's viruses and bacteriophages and all these things living with us in that location. And while there's sort of this in the bladder specifically, it's still sort of a blossoming field, and we'll put it that way to say we don't actually have that much information. But what we're starting to learn is that we think it works similarly to the way it does, say, in the skin or in the gut, and that those microbes are really, really critical in helping our bladder function normally. So at least in the gut, what we think happens is that those microbes interface with the body. So that's that host microbiome, interaction to actually help boost our immune systems. They actually promote better immunity when they're working right. They promote neurons to be just the right level of responsive, not too much, not too little. They help regulate the interface itself and how permeable that interface is. And there's a million other things that we think that they may also play a role in. The next sort of big part being what the metabolites of those bacteria are. So when the bacteria eat things or process things, and then they make all these metabolites. Those metabolites can interact with our bodies too to change the way that our organs function. And while not as much is known about how all of that works within the bladder, at least we're starting to sort of get into those ideas. And if it works in the bladder the way it does in all these other organs, then that's probably a really critical part of keeping the bladder and the whole urinary tract functioning the way that it's supposed to.
So there's really this protective mechanism that's happening too with having this microbiome. But I assume it's all about the balance, right, of the microbiome and trying to maintain that appropriate balance. When that balance gets upset and something overgrows, that's how we then end up with an infection or symptoms. How does that actually cause some of those symptoms in the bladder? You call it dysbiosis and leads to these lower urinary tract symptoms. Can you walk us through how that really happens?
Sure. Well, again, a lot of this is hypothetical because not really much is known about how this is actually working inside the bladder itself. And there's still a lot of questions that remain about whether it's a direct interaction of microbes inside the bladder itself, or whether it's sort of a byproduct of the interactions of those microbes in the gut that are somehow influencing through crosstalk at the level of the spine, or God only knows what. So a lot of it is hypothetical, but at least what the theory is, or the hypothesis is that those microbes may be interacting, with surface receptors on our urothelial cells inside that bladder lining and actually causing those cells to fundamentally change. So there was some interesting work, for example, to try to give one sort of example of how this might be, that in patients, say, with interstitial cystitis, there's some great work from the multidisciplinary approach to pelvic pain research network from the NIH, otherwise known as the MAP, that found that patients with a lot of bladder pain had these receptors that were sort of hypersensitized. They were just more reactive. And those receptors recognize bacterial components. And so there was this, hypothesis, again, which hasn't been proven, but is a very interesting idea to entertain, that maybe these bacterial populations, they're getting a little out of whack, a little overgrown, or the wrong kinds of stuff that are around. They're interacting with these receptors on the bladder themselves that are specific for those bacterial components. And then all of a sudden, you're having just a lot more cell signaling and a lot more stuff being activated inside cells. That's leading through a much longer process to sort of pain, production of inflammation or inflammatory mediators that stimulate nerves and irritate everything and leads to just general badness that we associate with interstitial cystitis. So this idea that you can have this imbalance in the bladder microbiome or the urobiome that leads to sort of downstream effects on the bladder itself is sort of implicated in a number of different lower urinary tract symptoms. So overactive bladder, there's some evidence for this there. Interstitial cystitis, bladder pain syndrome, there's some there. And I think there's a lot of question as to whether there could be something like this operating in what patients increasingly report as sort of this chronic UTI symptoms, where they've gotten UTIs and they used to kind of be intermittent, and now they kind of have these chronic symptoms. And we can get into a little bit later maybe how this might be related to antibiotics and antibiotics' ability to disturb our microbiomes. But that is sort of kind of, if we think of it as an overarching theme, the bacteria are really only part of the story. They're the part they get a little out of balance, but you need that reaction of the host on the other side. It has to interact with the bladder and cause something to kind of go wrong for us to really have that syndrome, right? So it's all about the host interacting with this altered microbiome, this dysbiotic microbiome that is no longer supporting normal activity and now is leading to something bad we didn't anticipate.
Yeah. And I think that's interesting that you brought up already this idea about chronic UTIs, right? And so it makes me think about when patients have recurrent UTIs, and they really do have UTIs, but having them recurrently, some of this maybe damage that's happening to the urothelial lining that's allowing for this hypersensitivity of the nerve endings in the urothelial lining that then certainly causes these symptoms, even though the infection is no longer there. So I think some of the work that you're doing is hopefully showing also that this response can be ongoing and long-term and have, long-term effects and not just that a simple acute effect at the time of the infection. That's interesting.
Absolutely.
So, we did an episode already on urinary tract infections with Dr. Ann Cameron from the University of Michigan. So I encourage you to listen to that. What we spoke about on that one was really a lot about guidelines or evidence-based medicine that provides us with the guidelines from the AUA SUFU guidelines committee to how best to prevent urinary tract infections. And so I just recently learned that they're going to be redoing these guidelines. The last time that they were published was in 2019. So there's always another look at the current literature and should those guidelines be changing. And Dr. Ackerman is chair of that committee, I just newly learned. So congratulations to that. So that'll be a work in progress. We'll hear about the results, in a year or two, maybe? Somewhere in there. I know it's a long process. It's a very long and arduous process. So kudos to you for taking this on and being chair of this committee. So we look forward to if there's anything new in our, evidence-based literature, right, that might guide us on how to take care of these patients. But just real quickly, we often talk about the upsetting the apple cart or, maintaining that homeostasis in the bladder. And in women, I often talk that they have 3 compartments down there, to say it colloquially, right? They have the bladder compartment. They have to maintain this homeostasis. They have the vaginal compartment to maintain that homeostasis. And then also the bowel, right? And it's really about maintaining the homeostasis and all of those together that helps prevent those urinary tract infections. So we won't get into the details of what all of that is. You can listen to that episode, the prior episode on BackTable Urology. But I did want to get into a little bit more about some of the discussions or some of the diagnostic tools that we have to try and figure out if somebody truly has a urinary tract infection. Because as you already alluded, there are a number of reasons why someone may have these UTI-like symptoms and not necessarily be of an infectious etiology. And it's really important before we put a stamp on it that's a true infectious etiology that we know really what it is. So we're very familiar with just the general cultures, but there are some other newer technologies today. What are the limitations, would you say, of our current standard culture system? And for the listeners, how does that work?
Sure. So when you do a standard, clinical urine culture, the way that we've been ordering them for decades, typically they take a very tiny, like a microliter of urine, and they put that on a plate and they sit there for a couple of days, and we're all sitting there waiting. The patients are refreshing their patient portals, waiting for these results to come back. And the limits of that are, one, it's slow. I think that's been, as we all know from the patients calling our offices asking, is my culture back yet? Is my culture back yet? We know that for somebody with an active urinary tract infection, to wait 3 to 4 days for culture and susceptibility can really feel like a lifetime for them. And so that's, I think, the biggest limitation is just the length of time it takes to really do a culture. But there's more to it than that, and both on the overgrowth and the undergrowth side. So the way that clinical cultures work is that we typically have 1 or 2 types of growth media, and those media, the stuff, the food that we grow the bacteria in, tend to grow specific types of bacteria better than others. And so, for example, E. coli, which is what we consider our most common cause of urinary tract infections, grows pretty well in these media, whereas some things that are more atypical pathogens don't grow very well at all or don't grow at all. And so there's kind of a debate about, hey, E. coli causes 85% of all of our urinary tract infections. But there's a little part of the back of my brain that's always wondered, is that because it really causes 85% of our urine infections, or is it because we grow those really well? So if there's any there, maybe that's the thing we're always detecting. And so I think it is probably the most common thing, but we really enrich for it in the way that we culture. And so some of the stuff that we might cause infections or that we're unclear about whether it causes infections don't grow so well. So it's really hard to assess them.
So what I really, just to put something in there, what I really hear you saying is that there are potentially a lot of other bugs that are there that could also be the problem, but we're not able to detect it with our current just, regular Petri dish culture that goes in the incubator for 2 days.
And there's also another sort of downside, which is kind of more of a technical issue, if you will, which is that because we now know that there's bacteria kind of in our urogenital tract, even a standard culture, even these standard clinical cultures, can overgrow things that may not have actually been problematic organisms. And this is kind of a huge thorn in my side. So for example, my own clinic where I see patients, my patients will go into the bathroom and they'll pee in their cup and they'll come out and they'll hand it to somebody, and that somebody will put it on a tabletop where it will sit for 5, 6, 7, 8 hours. And there is so much wonderful data to show that if you do not get that culture either in a refrigerator or in a stabilization solution within about an hour or so, you're going to have false positive results a lot of the time. I think it was like 40% of the time you're going to get a positive result when there wouldn't have actually been anything there doing it if you properly handled your urine culture specimens. And so I think that there is a lot that are actually details about that procedure that make it that we don't actually pay attention to and we don't necessarily always follow, that means that we can actually overcall things a lot of the time too. And then what you're going to get when you get whatever false positive that is going to be whatever grows really well on the tabletop at 30 degrees, right? It's not even going to be the thing that might even have been the most common thing on the inside of the body. So it's prone to a lot of mistakes. And it's problematic for us as clinicians because how many times do we get, say, mixed urogenital flora or, something that doesn't look like it should be a pathogen, or a staph epidermidis, which we probably think is not a pathogen, it's probably a contaminant, but we can't select for the right stuff. We often will have and I think that's one of those things, like staph epidermidis grows really well when you leave it out on the counter. So these are the kinds of things that end up with a patient calling us and saying like, I had this happen to me last week. I had a patient call me and be like, I had staph in my urine. She thought she was going to die because she'd heard about, drug-resistant staph infections from the hospital. And I was like, no, it's okay. But these kinds of things really mess up our ability to actually figure out what's going on. And so there's both these technical issues and the logistical issues and the sensitivity issues of a standard clinical urine culture that actually make it pretty unreliable. There was some good data that basically said it may be wrong as much as 50% of the time, which if you're a patient suffering from a UTI, that's a pretty awful thing to be told.
Oh my goodness. There's something called the enhanced quantitative urine culture. I don't know how it's being used, if it's being used clinically at all. I know it was something that started at Loyola University and the work that they've done there. You have some experience with it, but can you tell us a little bit more about how this is different than the regular culture and why it might be better?
Sure. So in an enhanced culture system like this, what you end up doing is instead of taking that like 1 microliter, we're going to take a much larger volume, say 100 times higher volume, and we're going to plate that out. And not only are we going to plate that out into the same kind of plates that we use for the standard culture, but we're going to use a bunch more different types of culture media that are going to be better at, say, growing types of bacteria that don't grow on our standard plates. And in doing so, you get a much wider range of bacteria and probably a pretty good representation of most of the stuff that's clinically important, at least as far as we know, in urinary tract infections. And so it's a way of basically saying, okay, if one of the problems with standard clinical culture is that we're not really allowing certain types of bacteria to grow, we're not providing them with the media and the food that they need, well, let's do a whole bunch of different plates and make sure that we have different conditions that'll allow us to grow the gram-positives, the gram-negatives, and everything in between that might be clinically important in a urine culture. And we're going to use a bunch more to give a better representation of everything that's there. And so those tests tend to be a lot more sensitive. And when you look at women either with or without symptoms, you can grow bacteria using these approaches from the vast majority of people, including healthy, sort of asymptomatic young women, showing that they're giving us a better representation of the bacteria that are kind of hanging around in the urinary tract.
So I think I've heard you speak about this before, and you mentioned that like almost all women, or greater than 90%, even those that are asymptomatic, would be considered controls, will grow something on these enhanced quantitative urine culture. Again, reinforcing the idea that we have a healthy microbiome. Just because we have some bugs in there doesn't mean that we have an infection, right?
Most people with these more sensitive techniques, and we'll probably get into this a little bit more as we go into some of the molecular diagnostic approaches, but what these techniques, both enhanced cultures as well as some culture-independent methods, have taught us is that if you look hard enough, you're going to find bacteria in almost everybody. And probably the ones that you didn't see it in maybe just were a little more hydrated that day or something, and you'd see it a different day. So we have to kind of interpret our whole view of infections and the world of, cystitis and all of that in this new light, understanding that not all bacteria are bad and that there's going to be bacteria there if we look hard enough, and understanding the difference between healthy happy colonization with good stuff and how that's different from the bad stuff causing a problem. And I don't think we know that yet. That's where the future is and where we need to be going.
Yeah, well, this might be a good segue into that anyway, before we get into the other culture-independent detection methods. But just to say that, an asymptomatic woman does not a UTI have, right? It really has to be utilizing some clinical judgment, what kind of symptoms are associated with this positive culture test that you have, right? The test itself isn't the be-all, end-all.
Yeah, and I think that's actually what some of the early data from using the enhanced culture methodologies was able to kind of show, was that you could find, E. coli in women that had symptoms of infection, but you could also find it in women who didn't have signs of infection or symptoms associated with infection. And even in the women who had negative standard cultures, who then went on to have positive cultures using expanded culture approaches, they didn't necessarily get better at a rate different than the ones that didn't have those things, that didn't get antibiotics. And so I think that I would love to see us reframe the question about UTIs in a different way and not say, do I have an infection? Do I not have an infection? Because I think we have to really, there's so much unknown about what bacterially defines an infection, and really try to focus again on, do we think antibiotics in a particular patient are going to make a difference in their clinical course? Will it, not just are they not feeling good? We can often say we know you're not feeling good, but there are times when people don't feel good and antibiotics are the right thing. And there are times when people aren't feeling good when antibiotics are really unlikely to make a big difference. And so I would love to see us reframe that question about how we treat UTI, not in terms of do they have an infection or not, but do we think antibiotics is going to help or make a difference in their clinical course?
Very well said. So let's shift now and look at these culture-independent detection methods, some of these newer molecular biology ways of detecting. Talk to us a little bit about what your experience with these are and what's out there.
Sure. Well, I think there's actually a lot of different ways of detecting bacteria. We talked a little bit about the culture-based systems, and that actually requires a bacteria to grow. It has to be alive, and it has to be able to grow in some media. And as we already talked about, there's some things that grow well in that condition and some things that don't. And there's been this question of, are we missing some stuff because we don't have conditions outside the body that are able to help those things grow so that we can detect them? And so there's been a lot of interest in recent years in using these culture-independent approaches where you don't have to have them grow. You can just detect either the bacteria themselves or some component of the bacteria. While there are a lot of different ways of doing this, the most common way of doing that is detecting bacterial DNA. And so what we do in that case is we're trying to isolate the DNA out of a sample, and we look and see, does that DNA match, some bacterial sequence that we know about? And there's kind of two major ways that we do that. And one is through what's called PCR, which is polymerase chain reaction, and the other is through sort of next generation sequencing or deep sequencing, or we're actually looking at the actual DNA sequences through some method or another. And so with PCR, what you're doing there is you are amplifying a sequence of DNA using primers that are complementary to that DNA. So you have a little fragment of DNA, it comes and it binds to a known sequence of DNA, and then it amplifies the sequence that's sort of downstream. So over cycles and cycles of doing these amplifications, you get this massive expansion in a particular sequence that you can isolate and recognize through one form or another. And what that allows you to do is actually say, is this bacteria's DNA sequence in my sample? And so the benefit there is it can be very specific. We can make those sequences as selective or not selective as we want. So we can sometimes just say, we're going to look for any staph, or you can say, I want to specifically make sure I want to look at staph saprophyticus, and I'm going to look at this strain even. There are even ways to get down to even strain-specific levels, although that's not typically what's done clinically, but it's a very specific way of doing it. And the other great benefit to PCR is it's what we call semi-quantitative. So, and what I mean by that is that the readout that you get can actually give you an approximate level of how much of that bacteria is in your sample. And we'll get back to the other version that isn't that way, which is sort of one of the great strengths of PCR, that it does have this ability to sort of create a readout of how much is there, not just is something there or not. Now, the downside to that is If you don't look for a bacterial sequence, you will not obviously see it. So most of the commercial methods that use PCR have, say, a panel of 10, 20, 40 bacteria. They're only going to be able to look for that panel of bacteria. So if something is atypical, or if it's a fungus, or if it's something else, a virus, obviously we're not going to see those things because we weren't looking for them in the first place. So you only see what you look for. And while it is more specific and wonderfully kind of more quantitative, you're going to be limited to what you picked in terms of what you're going to see. Now, so on the other side, we have the next generation sequencing or the deep sequencing approaches. And here, it's not at all selective. We're just going to sequence everything we can find in a sample. We're going to take the DNA out. We're going to take all the sequences. We're going to look for as much as we possibly can. And then you'll be able to sort of compare those to databases of bacteria and say what bacteria are there. Most of the commercial methodologies that use some kind of sequencing approach usually combine it a little bit with PCR to give you a little bit more targeted readout, because they're going to be also looking, and this is another aspect to these tests, at genes that are associated with antibiotic resistance. And so often you may see some sort of mixed methods kind of approaches where the test that you're using will use some sort of element of sequencing and some element of PCR to give you that extra specificity. But the sequencing approach just in general is sequence as much as you can and then figure out what those sequences are that you get back. Now, the benefit to that technology is that you don't just see what you look for. You're hopefully seeing a much wider range of things, but it's not quantitative in that you can't really say, we're seeing 80% is this bacteria and 20% is this bacteria. You may get a little bit of a sense of that. Like if there's a lot more sequences associated with one bacteria, it's much more likely that there's more of that around, but it is not really quantitative. So the reason that becomes important is that with your PCR-based techniques, there actually is the ability to create a threshold, right? You can say only if there are so many copies of this bacteria's DNA am I going to call this test positive. Whereas with the sequencing approaches, often you end up just kind of with like, well, it's there, it's not there. And that's kind of all you can say. There are some abilities to say, hey, this is there in much greater abundance, but it's a little bit more difficult. You can't really establish thresholds. So both technologies, PCR and deep sequencing, have been combined with tests that look for genes associated with antimicrobial resistance. And we could get into what that really means a little bit more if you want to. They're not a foolproof test of whether something is going to be susceptible or not susceptible, but it gives you some guidance. And the great benefit to both of these approaches is that they don't require that 3 to 4 days to sit there and wait with your cultures in the incubator. They're most of the time going to be able to come back much, much, much more quickly, usually within a day or two, giving you a result that's going to be a lot faster for your patient who's miserable.
I think I've even seen some things where they can come back as the same day, like 4 or 6 hours
absolutely.
later. I don't know if you have any experience with those. So what we're saying with this is that they're very sensitive. They're telling you all the things that are there in the urine, but sometimes not really able to tell us which ones are problematic and which ones are not. It's just giving you this whole, blanket approach of identifying everything that's there. So how do you see these best being utilized? I mean, I'll be honest, I've not worked at a place where we utilize these, but I see patients who come in from various concierge services or some urgent care situations, and they come in with all of this paperwork and say, all of this stuff is in my urine. I'm infected with all of this, and I've been on antibiotics, 3 different antibiotics for the last 3 months, and they sent me to urology to fix me, right? So what do we do with that?
So my personal opinion, which again only represents my own personal opinion and not of anybody else's, is that the way that these tests are being used clinically is exactly the wrong way. Because I think they actually do have clinical utility in the acutely ill, patient with uncomplicated UTI. Like, I think they actually do a better job at detecting a wider range of organisms, probably more accurately than a standard clinical urine culture. But the way that they're being used is in patients with chronic, irritative, or painful lower urinary tract symptoms. And there's absolutely no evidence for them being useful in that situation. And in fact, probably the reason you and I are seeing those patients is because somebody decided to test their urine, keeps giving them antibiotics, and lo and behold, they are not any better. And so you already kind of have a proof of principle that this patient who has gotten a million, broad spectrum antibiotics is not going to get better with that approach. And so again, that comes back to my general idea that our idea needs to not be, does this patient have an infection or not, or is there bacteria there or not? It has to be, does this patient get better if I give them bigger, badder, antibiotics? And I think usually by the time they get to me, it's pretty clear that's not going to be the case. So I actually do think, though, that the tests probably are better than standard clinical urine cultures in the context of that acute patient who comes in and tells you, oh my gosh, 4 p.m. yesterday, I started to feel this little feeling, and then everything started to burn, and now I can't leave the bathroom, and I'm so miserable, and it feels like I'm peeing shards of glass. That patient who's super convincing for having this acute UTI, probably, if you get that molecular diagnostic test or whatever test, is going to be much, much, much better and much more helpful at guiding the appropriate treatment of their infection, their antibiotics, whatever we need. And you're going to get it faster, and maybe you're going to get those antibiotic susceptibility genes that's going to help guide you a little bit better. So I actually think that they're probably great tests to have in that moment for the acute UTI patient. I think a lot of the problem is that we as urologists are not seeing that patient. We're seeing the ones who failed all the courses of antibiotics that came before. And that sort of should raise a red flag that maybe even if it is bacterially related, whatever is going on for that patient, whether it is a chronic, sort of like colonization with something mean and nasty that's irritating their bladder all the time, they are unlikely to get better with the 5th course of antibiotics that they've, because they've already gotten 4. I mean, I'm sure you've probably seen patients like this too, where they come in and they were like, I was on 2 weeks of IV blank. And you're like, oh my God, how did we end up here? And they're still no better, and they're still miserable. And I think at that point, we need to turn ourselves to what the patient's symptoms are, how we manage those symptoms. And I think that there is a certain amount of, if they've already been so treated, it may be that the dysbiosis, this imbalance in the bacteria that may be promoting some of these symptoms, may have been contributed to by all those antibiotics. And what we need to do instead is to focus on supporting their recovery so their body can actually get back to where it was before all of this started. Anyway, that just being a long way of saying, how are these tests used in clinical practice? I think they're often used as sort of like a Hail Mary on the part of providers that can't figure out how to make somebody better, when where I think they probably really have a lot of utility is in that management of the acute uncomplicated UTI.
Yeah. And again, you bring up the point, too, that, it's the symptomatic patient, right? You're putting your clinical judgment together along with this test, the results thereof, right? And to come up with the clinical picture or diagnosis that you're making, as opposed to just following some little algorithm that might not, fit the patient. So clinical judgment is definitely still warranted. There is still an art to medicine, right?
And especially in that situation, when you think about your goals of care, again, bring it back to the idea that our goals in taking care of UTI is not to obliterate the bacteria. And now that we know that everybody has some bacteria, that should not be anything we care about. The bacteria's presence or absence is sort of, not really that important. What we're trying to treat are the patient's symptoms. And if they have those acute, totally convincing symptoms of UTI, treat it with antibiotics. Sure, that makes sense. But if there's something else and you've given them antibiotics and they're not getting better, then just trying to obliterate bacteria that you find on a test is not at all treating the patient or treating the symptoms. You're treating the test. So the test is a tool. There's nothing inherently wrong with the tool, but there is something but it has to be used in the right way. And we as clinicians need to focus on that patient's symptoms, making the symptoms better. And especially if somebody's already shown that 5 courses of antibiotics haven't made it better, you can probably take that as good evidence that we need a different shift in our thinking about that particular patient.
Yeah, let's talk for a second, because you already brought it up a little bit, this idea of a chronic UTI. We see patients all the time that are diagnosed with a chronic UTI. They say, I've had this UTI, and they may have had a positive culture, and it was 8 months ago, and they said, I still have the same symptoms ever since, or I've had this for 3 years, this UTI. I've never been a believer in this idea of I have this smoldering chronic infection that requires antibiotics on a daily basis. But you did allude to a little bit of that change in the microbiome that happens, and sometimes, I don't know, what do you think about that? You think patients maybe with the disrupted urothelium that there can be sometimes some embedded organisms that may not be a full-blown infection but causing some of this unpleasant symptoms, or...
Yeah. No, it's a really rough thing because I think, anybody who's living that experience is going to know how disruptive it is to their life, how horrible it is, how painful and just miserable and debilitating it can be to live with those chronic symptoms. I think what I'd love to say is I think the jury's still out on what exactly that syndrome is and what it represents. I think it is perfectly possible that it could be microbially related, and maybe it's not a full-blown fulminant infection. Maybe there is this altered or disrupted microbiome that's interacting with the bladder in a way that's causing these chronic symptoms. The thing I would come back to say is that, again, that doesn't have to mean it should be treated with antibiotics. And that's, I think, the part that is the hardest thing to convince patients of. But maybe when you actually have a longer discussion, it's actually not that hard because they know that they haven't worked and they know that they're not getting better. And so having a shift in our approach doesn't have to be that crazy. And so I think it basically, I can't say what it is. No one knows what it is. We got to do more to figure out what's actually going on for these patients. But even if it is bacterial, antibiotics don't seem to make it better. And there have been 2 long-term studies that looked at longer, higher dose antibiotics, and they reported that patients actually transiently felt better while they were taking those antibiotics. They felt better, but the problem is what happens when they stop them. And that when they stop them, everything just comes right back. And for me, I think that means that the effects of antibiotics are one of 2 things, or maybe both. One is that there are a number of effects that antibiotics have on inflammation. And so they do tend, sort of separate from their impact on infections, to tamp down inflammation. In fact, there are even conditions where we use antibiotics to manage inflammation as a sort of using this as this bystander or byproduct. I don't know what you call it, but this secondary effect of antibiotics to treat an inflammatory condition. So they have these effects, and that could be one way that they're working. Or it could be that there is this sort of overgrowth of abnormal bacteria, and long-term antibiotics does help control it while you're on it. But we know with just huge amounts of accumulating data that long-term antibiotics, the more antibiotics you get and the broader spectrum antibiotics that you get, the more health problems come as a consequence. And so short-term gain, long-term big loss, right?
Right.
And there have even been situations with these long-term courses of antibiotics where people have been seriously ill, nearly dying from the side effects of those antibiotics. And so I think while I totally get the desire for it, and while you're on them, you feel good, I think we have to try to find other ways of dealing with it. And so what I've had luck with in my own practice is really just that for a lot of these patients, we got to support them symptomatically, and we got to give their body ways to restore a more normal microbiome. And that may be things like non-antibiotic prophylaxis. I know we talked with Dr. Cameron about those things, but a lot of those non-antibiotic prophylaxis approaches like cranberry, methenamine, just water intake, like some of this stuff can help control that overgrowth of bacteria without having the side effects of antibiotics. And that would give you enough room, if you will, to kind of allow your body to begin to recover and to restore that microbiome with the good stuff, the stuff we should have, the stuff we need around to help control the bad stuff, to help fill the space, to help promote better bladder lining function, better permeability barrier, better, all these things that our microbiome is needed for. And so again, just want to come back to say no judgments on what the condition is. It very well may be a type of infection or a bacterially mediated disease, but I think treating it like an acute UTI is generally unsuccessful and probably fraught with some potential for longer term complications of which we have not seen the worst of it yet.
Yeah. And I love that. I mean, it's all really about, for the long-term goal, is reestablishing the normal homeostasis or the balance. Again, in all three of those compartments, you mentioned some of the things that are recommendations for the bladder, but when you look at the vaginal area in the woman, making sure the lactobacillus, the pH are where they need to be. We do that usually with vaginal estrogen supplementation. And then don't forget the bowel and doing some probiotics, right, for bowel gut health to try and reestablish good, healthy bacteria, especially when we've been on so many antibiotics that have wiped out everything.
Absolutely.
All the bad guys, but the good guys too, right? And now you have to reestablish and hope it gets reestablished with good, healthy stuff. So it's really important for the long haul to look at trying to see how can we reestablish that norm. So I love that you pointed that out. So I guess my last question would be, again, about some of these non-culture-based diagnostic methods and what I think you've been involved in some clinical trials with them. I don't know where they're going today. Are there new ones being developed? Or, I think that there's some interest certainly in, the medical community to know how to use these appropriately. So you've given some good advice in the acute setting, which works well. But should we be focusing also on trying to develop more diagnostic algorithms that include some clinical criteria? Or, should we work with these companies to help them to learn how to utilize these tests better? Because I think they are good tests too. It's just how they're being used.
I'd love to see some more guidance that could come out of these approaches. And I wish it were not that way. I mean, what we can definitely say is that even just using standard clinical culture, we do a pretty terrible job of taking care of UTIs. So having better biomarkers, if they're, for lack of a better term, it doesn't have to be a particular molecule or anything, but either clinical criteria or actually molecular biomarkers that can help give us some guidance as to whether somebody needs antibiotics to manage their symptoms or not. And so there is preliminary data from a number of different groups about different biomarkers that are associated with UTI and whether there may be some utility in combining the molecular diagnostic testing with some of these markers. I think that's a great possibility. Frankly, just combining it with the standard components of a urinalysis, if somebody has an E. coli infection, they should have positive nitrates. Like, that should be a thing. They should have leukocytes, they should have nitrates, and they should have the bacteria. Like, those things should go together. And so I cannot tell you how many times I've seen people either not order the urinalysis or just they are negative and then they find the E. coli and they treat them anyway. I get it. It's so hard when you have a symptomatic patient and you have a positive urine culture to not treat it. And I think that's the caution, right? We've already seen that that's an issue that we face just using our standard clinical cultures. And so now if we have a test that's going to detect bacteria in nearly everybody, if you're sending it without exerting your clinical judgment, you are going to treat a lot of people inappropriately. And so how do we improve our clinical judgment? Because sometimes it is really hard to know, is this person really infected or is there something else going on? So I think that these approaches of combining the urinalysis with the bacteria, because some bacteria are nitrate negative, but we know which ones they are. So we can make that, like, that's not hard to build. It's not even AI. It's just an algorithm. So there are ways that we can combine data we already know about with this molecular diagnostics to give us better help in terms of using our judgment and hopefully actually give people a little bit more courage to not treat things when they come back. Because I think that's for these technologies to really be a help and not terrifying in terms of leading to massive, antibiotic resistance across the world. There needs to be they need to empower us to decide not to treat in a way. You know what I mean?
Yeah, totally.
While they are very good in certain situations, if we just indiscriminately use them for anybody who comes in with lower urinary tract symptoms, then it'll be even worse than it is right now, and it's already not great. So, we ran a study in our healthcare system, and we said of everybody that got a primary diagnosis of UTI and had no other secondary diagnosis, who came in to one of our emergent care facilities, urgent care or emergency rooms, only 17% of the people prescribed antibiotics actually met criteria for having a UTI. So, and that's not an outlier. There's plenty of other data out there to corroborate those kinds of numbers. So if we're wrong more than 80% of the time, having a test that detects bacteria in everybody could be devastating for us. unless we use our judgment. And so I look to these companies to help us a little bit with that, try to combine some of these tests with other ways of giving us a little bit more guidance, but also as a plea to providers to say, have the courage to not treat when you don't think it's actually going to make a big difference. And I sort of feel like there's a couple clear situations like that when somebody's had symptoms going on for 3 weeks, or they don't have that acute onset when you've treated the bacteria and the culture totally appropriately and they're not responding. Like, these are probably situations where your patient is not acutely in danger of ending up with pyelonephritis in the hospital. So take the time to do a much more careful evaluation, see if you can figure out if there's anything else going on. I think if we could all just do that, it would make a really big difference.
I know when I talk to patients that are very complicated ones and come to me with these huge stories, I say, someone was really just trying to help you in the moment because you were having symptoms. But if we keep on this course, we're creating a bigger problem. By trying to solve your immediate problem, we're creating a bigger problem. And we need to think outside the box and down the road. And that's how I kind of am able to at least penetrate the minds of the patients a little bit, because they are so hooked on the antibiotics. They're oftentimes, this is the only thing that helps me, and this is what I've been told for years. So this, of course, is what how they've been educated themselves. So, in their defense, it's not their fault, right?
Absolutely, yeah. And nobody is making it better or doing anything else to help them. And so I think it's patients really do express a huge amount of frustration with access for care, especially acute access when they have these symptoms. And so, hey, it's not unreasonable. It's, in fact, quite understandable. But the problem, I think, is that to have that conversation takes time. A lot of people as clinicians don't have a lot of time, and we need to find a way.
Yeah.
We need to find that time, I guess. We need to find that ability to take that extra little bit of time to counsel them, like you're talking about counseling them about the potential long-term consequences of excessive antibiotic use.
Well, this has been a very interesting episode. Thank you very much for helping to enlighten us about all of these new innovative technologies and about your expertise in UTIs and this microbiome and the management thereof. So this has been very interesting. I appreciate you giving us your time today.
Thanks. It was a lot of fun.
Thank you, everyone else, as well, for listening. That wraps up our session today on the microbiome of the bladder and advanced UTI detection technologies. Again, this is Suzette Sutherland, your host for BackTable, signing off. Until next time.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.